all. Today we're going to be talking about Chapter 5, which is focused on the anxiety disorders, specifically trauma, anxiety, OCD, and related disorders. So first we'll talk about PTSD and acute stress disorder, followed by specific phobias and agoraphobia, social anxiety disorder, panic disorder, generalized anxiety disorder or GAD, separation anxiety disorder, obsessive compulsive disorder or OCD. And then we'll focus a little bit on anxiety disorders in older adults. So PTSD, or post-traumatic stress disorder, here it says PSTD, it should be PTSD, is a consequence of experiencing extreme stressors. So according to the DSM-5, it requires that individuals directly experience or witness the traumatic event or learn that an event happened to someone they are close to, and they experience repeated or extreme exposure to details of a traumatic event. So generally when we see people with PTSD, they themselves have been the victims or witnessed a traumatic event. In odd cases, hearing about something that's happened to someone they're close to or experiencing repeated exposure to details of a traumatic event can also cause it. But those are rarer, and you have to kind of be a little discerning when making diagnoses based on the second two criteria. So the symptoms of PTSD include repeatedly experiencing of the traumatic event even after it's happened. So you have nightmares, flashbacks, thoughts you can't get rid of, persistent avoidance of situations, thoughts, or memories associated with the trauma, so you don't go certain places or you don't think about certain things. You have negative changes in your thoughts and your moods associated with the event, so it's very negative. You generally have hypervigilance or chronic arousal. Those of you who have seen Homeland know that, when they come back from war, people can be very jumpy and easily startled. So, you tap somebody in the shoulder and they have an over-exaggerated, response. And then there's PTSD with prominent dissociative symptoms, which result in dissociation, which is kind of like when people space out, but it's kind of to more an extreme extent. But it's different facets of sense of self or consciousness, and they become disconnected from one another. It kind of feels like you're looking from the outside into your body, like when you see on TV those out-of-body experiences when somebody's looking in on themselves. That's how people often describe dissociation. Other related disorders to PTSD are acute stress disorder, which occurs in response to trauma similar to those like PTSD, but it's diagnosed when symptoms arise within 1 month of exposure to the stressor and last no more than 4 weeks. So basically, if something bad happens to us and we're feeling, having some long-term consequences of that, but it's not resulting in PTSD, we can get diagnosed with acute stress disorder. And adjustment disorder is when it doesn't meet criteria for PTSD or acute stress disorder, but people have a response to a traumatic event. So, for example, after 9/11, a lot of us were feeling pretty worried and pretty upset, pretty down, which is very normal, but it could be characterized as an adjustment disorder until we were feeling better. So some of the traumas that lead to PTSD are natural disasters like, hurricanes, tornadoes, earthquakes, human-made disasters like wars, traumatic events like car accidents or rape and other kinds of sexual assault. So there are various theories of PTSD. First is environmental and social factors that may impact it. So the severity and duration, the individual's proximity to trauma, and the amount of social support available. So, it depends, watching something horrible happen, like somebody being killed in front of you, or you yourself being in a traumatic accident or something like that, and you're being right there, and if social support is not available, so you can't talk about it and process it, then this increases your risk for PTSD. Psychological factors include pre-existing conditions like depression that can aggravate susceptibility, coping strategies also, if you have kind of avoidant coping strategies and you weren't able to talk about some of the things that transpired. There are also gender and cross-cultural differences. Women are more prone to PTSD. African Americans have higher rates of PTSD than people of other racial and ethnic backgrounds. And there are also cultural manifestations of anxiety, so depending on the culture where you're from, you may not exhibit PTSD in the same way across culture. So when you look at the biological factors, in terms of neuroimaging, the brains of people with PTSD are more reactive to emotional stimuli. So you'll see the brain lighting up more quickly with response to more innocuous emotional stimuli. And biochemical findings show that there's a physiological response to stress which is exaggerated in PTSD sufferers. So minor stressors can lead to a more acute response. Exposure to extreme or chronic stress during childhood also increases vulnerability. So if you were abused or neglected, this then increases the likelihood that you might get PTSD in response to a more extreme stressor. And the vulnerability to PTSD can be inherited. So treatments for PTSD, the goals are to expose clients to what they fear in order to extinguish that fear. So what happens is when people have these traumas, they try to squelch them and they don't think about them because they're so distressing. But then those traumas have an ugly way of rearing their heads in your nightmares, flashbacks, thoughts you can't get rid of. And it's only by reliving the trauma and exposing yourself and not feeling so impacted by it that you're actually able to kind of move on. It's never going to be okay, but it will go to the point where it's not affecting you. You also want to challenge distorted cognitions that contribute to the symptoms. So if there's any kind of maladaptive beliefs surrounding the trauma that that it was your fault, that you could have done something, because obviously in many cases has nothing to do with you. And you're also working with your client to reduce stress in their lives so that they can cope with things more effectively. Cognitive behavioral and therapy and stress management are kind of the most common treatments for PTSD, including systematic desensitization, where you're gradually exposing people to the stressor. So stress inoculation therapy, where therapists teach clients skills for overcoming problems that increase stress and result from PTSD. So you kind of build up their resistance to stress by, it's kind of like, when people get vaccinations, like you're giving people a little bit of the live vaccine so that their body can develop an immunity. And so in stress inoculation, you kind of give them a little bit of stress and then you teach them how to cope so that they can cope with larger amounts of stress. Biological therapies, which are basically medications, involve selective serotonin uptake inhibitors and benzodiazepines. So next disorder we're going to talk about are specific phobias, and these are unreasonable or irrational fears of specific objects or situations, and they're categorized in the DSM-5 according to animal type, natural environment type, situation type, and blood injection injury type. So these are, your fear of spiders, your fear of heights, things like that. So agoraphobia, on the other hand, is where people fear that they might have trouble escaping if they become anxious in open spaces, so they feel they'll embarrass themselves if others notice their symptoms or their efforts to escape. And in many extreme situations, people actually don't even leave their house because they're too afraid of being in such a situation. So why do we get phobias? So there are various different types of explanations. The behavioral one is that it's negative reinforcement, so reduction of anxiety reinforced by avoidance of the feared object. So by staying away from, let's say if we're uncomfortable around spiders, by staying away from them, our fear is decreased, and it reduces anxiety. There's prepared classical conditioning, because we have conditioning of fear to certain objects or situations. So you'll notice that the things we're afraid of, like dogs, spiders, and snakes, are often things that can harm us. So biologically, it kind of makes a lot of sense. Or heights, for example, we can fall down. So there might be some biological predisposition to be afraid of these things. And then biologically, related people share phobias, but that could also be learned. So it's unclear how much of that is biological and how much of that is learned. So the behavioral account of phobias can be seen in the Little Albert example, which I believe we've already discussed. But so Little Albert was not afraid of rats. He kind of liked them. He was actually he was able to be in the same room as a rat, but he was scared of loud noises, like the banging of a bar, which made him cry. However, then what they did, Watson paired the banging of the bar with whenever the white rat was presented. So whenever Little Albert saw the white rat, they also banged this bar, which made him cry. So then by seeing the white rat, it led him to cry. This was also generalized eventually for the poor little fella to all like white fuzzy stuffy things. So he developed a lot of fears, and obviously this today would be unethical. So behavioral treatments of phobias involve exposure to extinguish the person's fear. So they can be done either gradually by systematic desensitization, where you kind of have a spider across the room and gradually you move closer until eventually you're able to hold it, or you can have flooding, where it's like the fear factor, where they put you in like a cage with spiders or whatever, and you just have to stay there until your anxiety decreases to a level that's manageable. Both work. The latter is more terrifying, but yet more rapid. Most people, though, prefer systematic desensitization. Modeling is when you watch other people and then you do so accordingly. I do that with my children, for example. If they're scared of something, I show them first so then they can model, and I try to model unscared behavior so they can do that themselves. There's also the applied tension technique, which is increasing blood pressure and heart rate to keep people from fainting when confronted with a feared object, because that's one of the fears that people have, and in blood phobias that's what actually happens. It can be treated by benzodiazepines, but that kind of doesn't really solve the problem. It just decreases the anxiety. And so really, the only true treatments are the exposure treatments. Social anxiety results when people become anxious in social situations and are afraid of being rejected, judged, or humiliated in public, and focus on avoiding such events. So it's really important in diagnosing social anxiety disorder is really the cognitions, because people really have to be afraid of being rejected, judged, or humiliated. It's different in agoraphobia. It's not, fear of being in open spaces, but it's really this fear of being judged. We find it more commonly in women, and it develops either in the early preschool years or in adolescence. There is some genetic basis for it because they find it runs in families, but people also who have social anxiety disorder have excessively high standards for their social performance, and they judge themselves very harshly, and they also focus on the negative aspects of social interactions and evaluate their own behavior harshly. So whenever they're in social settings, they're very much judgmental of themselves, much so than other people are. Treatments for social anxiety disorder involve SSRIs, SNRIs, serotonin norepinephrine reuptake inhibitors, and again, especially with the anxiety disorders, a lot of these medications can, help calm you down and mask some of the symptoms, but none of these medications are treatments. The only real treatments are the behaviorally based exposure treatments, which we're talking about as well. So in cognitive behavioral therapy, you kind of identify the negative thoughts that people have, and you learn how to dispute these cognitions. There's also mindfulness-based interventions where people focus kind of on breathing and being in the here and now so that they don't kind of focus on the negative thoughts. There's also exposure-based techniques whereby people, put themselves in situations where they might be judged, and they just kind of have to stay there until they remain calm. Panic disorder involves occurrences of panic attack that occur without being provoked. So many people have panic attacks. It only becomes panic disorder when people start to fear or avoid certain situations because of fear of having a panic attack. So a panic attack is a short but intense period which people experience many symptoms of anxiety, where they think they're having a heart attack or they're going to die. They have rapid breath, they feel lightheaded, etc. So in panic disorder, people worry about having these attacks and change their behaviors as a result of this worry. People often feel like they might have a life-threatening illness, and you'll see people with panic disorder, they're going to go to the hospital, things like that, to get it checked out. In terms of panic disorder, there's a heritability. In fact, it's estimated that 43 to 48% of it is heritable, that you get it from your family. And it's triggered in sufferers if they hyperventilate or inhale small amounts of carbon dioxide, ingest caffeine, or take infusions of sodium lactate, or breathe into a paper bag. So actually one of the ways that treatment goes is that you induce panic-like states and have people kind of try to calm themselves down, and you challenge some of their cognitive distortions. They've actually found that people have dysregulation of the norepinephrine system in the locus ceruleus, and there's a biological basis to panic disorder. So you can see here that these are the areas of the brain involved with panic disorder, and that it has a much more biological basis than some of the other ones. So people who are prone to panic attacks tend to pay very close attention to their bodily sensation and misinterpret them in a negative way. So if they feel their heart beating because they've just run, they might interpret that as they're about to having a panic attack. And they engage in snowball catastrophic thinking, exaggerated symptoms and their consequences. So they start thinking, this means I'm having a heart attack, which means I'm going to die, I need to get to the hospital. They also have unfounded beliefs that bodily symptoms have harmful consequences, and they also have high interoceptive awareness, means heightened awareness to bodily cues that signal upcoming panic attack. And then these cues became conditioned such that, once they feel some symptoms, it just leads to a full-blown attack where they could divert it. And then we have what's called the conditioned avoidance response, and so it occurs in certain specific situations which are perceived to be aversive, and then it reduces panic symptoms by reinforcing avoidance behavior. So people then start to become agoraphobic, so you can have panic disorder with and without agoraphobia. because people then start to stay inside because they start to worry that being outside is going to cause their panic attacks, or being in public, and so they just stay inside, or they become so afraid of it. So here's an integrated model of panic disorder where you have the genetic vulnerability, which leads to the cognitive vulnerability and the biological vulnerability. Then the person has anticipatory anxiety, where they associate certain situations with panic attacks, and it results in panic disorder, and panic disorder with agoraphobia. So treatments for panic disorder include medications. Again, medications can mask or decrease the symptoms, but they don't get rid of them completely. What I would recommend would be cognitive behavioral therapy, where you practice relaxation and breathing exercises, identifying these cognitive cognitions and challenging them. Relaxation and breathing while experiencing panic symptoms during sessions. So you have them on a spinny chair and you would actually spin them around, for example. You'd then work on challenging these catastrophic thoughts and gradually expose them to increasing levels of panic and work with them on coping and being able to handle it. Oops. Okay, now we're going to talk about general anxiety disorder, also known as GAD. So GAD is really being anxious all the time. So being anxious more of the time than not for 6 months. You're worried about life. You're worried about pretty much everything, and it's more common in women than men. So some of the theories of general anxiety disorder include emotional and cognitive factors like experiencing intense negative emotions, showing heightened reactivity to emotional stimuli in the amygdala, making a number of maladaptive assumptions about the world being more dangerous, you'll forgive me, and focusing on detecting possible threats in the environment and in unconscious cognitions. Some biological factors.
Daddy!
People with generalized
Is it hi, Daddy?
Excuse me, I'll have to
Is
resume
it
this
hi,
later.
Daddy? It's hi, Daddy.
Should have known better than to record with a 3-year-old running around, so they're eating now, so hopefully I can continue a little bit more without further distraction. But some of the biological factors are that people with generalized anxiety disorder have a deficiency of gamma-aminobutyric acid, or GABA, which results in excessive firing of neurons through many areas of the brain, so that might cause people to worry excessively, but it's not clear what came first, the chicken or the egg, if the worry then caused this. It results in a person experiencing chronic diffuse symptoms of anxiety, so it's kind of like the feeling of constant worry. Your shoulders are tight, you have muscle aches and pains, and there's just this kind of feeling in your chest that you're anxious. There's a modest heritability with GAD. So cognitive behavioral treatments focus on helping people with GAD by confronting the issues they worry about most, challenging the negative catastrophic thoughts. You do a lot of coping strategies and planning and trying to solve problems and things like that. Biological treatments include benzodiazepines and tricyclic antidepressants, and then selective serotonin reuptake inhibitors. Again, not a solution. It helps to decrease the levels of anxiety people are experiencing, and especially if they're sleep deprived, it can be very helpful to take some medication, but it's not a long-term solution because you want to teach people how to cope with these feelings on their own. Separation anxiety disorder refers to becoming anxious and upset if separated from primary caregivers. So, most kids get upset when they're separated from their primary caregivers, and that's very normal. But this is kind of very much extreme. So it has to persist for at least 3 weeks, and by then, after 4 weeks. After 4 weeks, most kids will adjust to their environments. I mean, they still may not like it, but they're able to function. But somebody with separation anxiety disorder has a significant impairment in functioning, and the child would not be able to function away from the primary caregiver. Biological factors include a tendency towards anxiety and behavioral inhibition. It causes kids to be shy, fearful, and irritable as toddlers, cautious, quiet, and introverted as school-age kids, and so they don't have a lot of friends other than their primary caregivers, and so they just feel very much attached. There are also psychological and sociocultural factors, so kids learn to be anxious from their parents as an understandable response to the environment, so their parents may be more anxious. So for treatment, cognitive behavioral therapy teaches skills for coping and challenging cognitions that feed the anxiety. So fears that mommy and daddy won't come back, you would explore that. Learn relaxation exercises to practice when separated from parents. And challenge fears about separation and use self-talk to calm themselves. So teaching the kids skills so that they can talk to themselves and talk themselves down when they're feeling worried and away from their parents. Medications can also be prescribed, although first of all, I'm not pro-medication, as you may guess, for many of these disorders, but for children especially, there's still unknown side effects of a lot of them, and so these would be off-label prescriptions for children. So now moving on to obsessive compulsive disorder. You probably have seen this. If those of you who've watched ever the TV show Monk, you see the main character has OCD. Also, the movie As Good as It Gets with Jack Nicholson, he portrays an individual with OCD. So obsessions are thoughts, images, ideas, or impulses that are persistent, and they uncontrollably intrude upon your consciousness and cause significant anxiety or distress. So it's kind of like if I right now told you not to think about the white elephant, it would be very hard for you not to think about the white elephant. But somebody with OCD constantly has thoughts like this, like that they're irrational thoughts. They're thoughts like they ran somebody over even though there's nobody there, that they're being contaminated by germs. Whereas compulsions are repetitive behaviors or mental acts that an individual feels that they must perform. And it's different from stress-related diseases, but it usually begins at a young age, and it tends to be chronic if untreated. Because of the early onset, there's a large literature suggesting there's heritability to it and that it runs in families. So common types of obsessions in OCD are thoughts and images associated with aggression, sexuality, and religion, like the thought of hurting a baby, sexual thoughts about Jesus, things like that are very disturbing to the individual, and though the person would never act on them, they would never hurt anybody, but they have these thoughts of stabbing other people, for example. Obsessions about symmetry and ordering, so things always have to be matched or equal on either sides. And then there's the contamination cleaning compulsion, so people are feared of being contaminated by germs or viruses or OCD. There's also hoarding. You've probably watched television shows about that now. It's kind of popular. It's closely related to OCD, but it's classified as a separate diagnosis in the DSM-5. Under DSM-4, it used to be considered part of OCD. So there are hair pulling disorders, so when somebody repeatedly pulls out hair, resulting in noticeable hair loss. You'll see this in their eyebrows, their eyelashes, or they'll have bald spots in their head, and it's called trichotillomania. There'll also be skin picking disorders. So we're currently picking scabs or places on skin causing significant lesions that often become infected and cause scars. And we all pick and we all pull our hair sometimes, but this is above and beyond that. It gets to the point where it's causing significant distress to the person. And then body dysmorphic disorder, people who are excessively preoccupied with a part of their body that they believe is defective but other people see as normal or only slightly unusual. People think that Michael Jackson had body dysmorphic disorder and hence why he went under so many surgeries. So theories of obsessive compulsive disorder and related disorders is their biological theories. So there's a focus on the circuit in the brain involved in motor behavior, cognition, and emotion, because response to medication is very good with OCD and the symptoms decrease significantly. And as I mentioned earlier, our genes help us determine who's vulnerable to OCD. So you can see these are the areas of the brain that are impacted by OCD: the basal ganglia, cerebral cortex, the thalamus, cerebellum. So some of the theories of OCD and the related disorders, the cognitive theory that people who have OCD are depressed and generally anxious much of the time, and they have a tendency towards rigid or moralistic thinking, so very black and white. And they tend to believe that they should be able to control all their thoughts, and in doing so they actually feel much more out of control. And they have trouble accepting that everyone has horrific notions from time to time, and they focus on having these thoughts. Like, for example, whenever I walk through Penn Station and I see a policeman with a gun, I always have the thought of like reaching and grabbing his gun. Not that I would ever do that, but I guess all of us have these thoughts, but I guess somebody with OCD would focus on that and wouldn't be able to stop focusing on that. And that compulsions develop largely through operant conditioning, in that when they do the compulsions, the anxiety decreases and therefore it reinforces them to do the compulsions. So biological treatments involve antidepressants, serotonin-enhancing drugs, but they can have significant side effects. CBT is actually used quite frequently with a technique called exposure and response prevention, where you expose the client to the focus of the obsession and you prevent the compulsion that results in decreasing the anxiety. So you would have them, and I know this sounds gross, but this is literally what they do, have them, touch a toilet bowl and then not allow them to wash and have them sit with the anxiety. You would have them, if they're worried about stabbing somebody, you would have them, put a knife to somebody's neck and stay there with it until the until the obsession subsides. So this challenges the individual's moralistic thoughts, excessive sense of responsibility, and maladaptive cognitions. And as they're exposed to this, the anxiety goes down. And while it doesn't necessarily cure the disorder, it does decrease the impairment and the anxiety significantly. So here you'll see the vulnerability stress model for anxiety, where you have the biological, psychological, and social vulnerabilities. And then when you have a specific new stressor or trauma, like a PTSD, where you have a trauma, or you have, a new baby or a change in environment, sometimes for people that have these vulnerabilities mentioned on the left, this results in an anxiety disorder. And we all have various levels of anxiety, but some people have them more than others, and it's thought that those who have more anxiety-related disorders have increased levels of vulnerability.